Hey folks, welcome back to our lab review sessions. This one is going to talk about clinical chemistry. So I'm going to quickly go over, review some of the major biochemical markers that we look at in vet medicine, just so you have an idea of what's what and why we look at what we do. Okay, so we're going to start talking about protein assays. So couple of notes about proteins. So they're not specifically a liver function indicator, but most plasma proteins are produced by the liver. So if we have liver disease or any change in liver function, then often we will get usually low plasma proteins. Some proteins are produced by the immune system. So you'll remember that one of the big proteins involved in the immune system is immunoglobulin. So that's a globulin protein, and so we definitely get quite a few proteins from there. Alterations of protein concentrations occur in a variety of disease conditions, primarily liver and kidney disease, but also gastrointestinal disease, skin disease. So basically there's lots of reasons we can get, usually again, low protein levels. There are over 200 proteins in the body. Seems to me there's probably a whole lot more than that, actually. Some proteins change dramatically with disease conditions, and others change only very little. So there are age-related changes in plasma protein concentrations. So basically, you have to take that into consideration when you're dealing with older animals. Most commonly in vet medicine, we perform 3 different protein assays, and that's total protein. That's the easy one that you can do yourself any day in clinic. Albumin, and we do this, of course, in our automated chemistry analyzers, and then fibrinogen, and that's part of, if we're looking at the clotting cascade, that's one thing we look at. So just a quick review of what plasma proteins do. Uh, they are, of course, a large part of the structural matrix of all cells, organs, and tissues. They maintain osmotic pressure, so they help to keep blood in the blood vessels, for instance. They serve as enzymes for biochemical reactions, and of course, our bodies rely on those enzymes in order to basically work at all. So very, very important. They can act as buffers and acid-base balance. Again, very important because we need our pH to be at just the right level or our enzymes won't work and our bodies will shut down. Plasma proteins are also hormones, some of them. They function, of course, in coagulation of the blood, as I just mentioned with fibrinogen, and they defend the body against pathogenic microorganisms. You guys know all about that from immunology. And they serve as carrier molecules for a lot of different things in the plasma. Very, very important. Total protein. So total plasma protein includes fibrinogen. Total serum protein does not. And why is that? Well, plasma comes from unclotted blood. Serum comes from clotted blood. So if we allow the blood to clot, that will use up the fibrinogen and there will be none in the serum. Makes sense, right? There's a few things that can alter total protein concentrations. Well, more than a few really, but here are some. Altered hepatic synthesis, so the liver's not making as much protein as it should. Often happens in liver disease. Altered protein distribution, maybe the circulatory system's not working as well and the protein's not making it to where it's supposed to be. Altered protein breakdown or excretion. Again, usually liver, maybe GI would be responsible for that breakdown. Excretion, usually kidneys. So also some GI. So maybe there's some issues with those organs. Dehydration, of course, we have dehydration. That means the fluid portion of the blood is less, so then the proteins are going to seem like they're more. So they'll be higher. And then overhydration, the opposite happens, and protein's going to look low, even if it really isn't. It's just there's too much fluid in the blood. Total protein measurement is really valuable in determining hydration status. So I just talked about hyperproteinemia, so elevated proteins being seen with dehydration, and then the opposite with overhydration. We can use this also to screen patients with edema, so that's basically fluid buildup in the tissues, ascites, and you'll remember ascites is free fluid in the abdomen, diarrhea, weight loss, hepatic and renal disease, and blood clotting problems. There are two primary ways that we test for total protein. The one that's really easy to do in clinic is refractometer, and that estimates the refractive index of the serum or the plasma. You all know how to use these. You've done it in your lab rotation, and you've probably done it in practice. So it's fast, it's inexpensive, it's accurate, it's great. So this is a really great, easy way to test total protein. The other way is a burette, not as common, but it measures the number of molecules containing more than 3 peptide bonds in serum or plasma. It's simple, it's accurate, again, not usually used in clinic. There are other methods of testing that are done in research and reference laboratories. You don't need to worry about it. There's, electrophoresis, that sort of stuff. One kind of interesting thing is they can do with electrophoresis is they can find what type of protein they're actually seeing. So we've got albumin here, and then we've got globulins, alpha, beta, gamma globulins. And gamma globulins, if you remember, like immunoglobulin G, for instance, very important with the immune system. Albumin is one of the most important proteins in plasma or serum. It makes up about 35 to 50% of the total plasma in most animals. It's huge. So basically, if we have hypoproteinemia, it's usually because we're losing albumin. Albumin is made in the liver cells, in the hepatocytes. So again, any diffuse liver disease that's actually injuring those cells or affecting those cells is going to result in a decreased production of albumin. Renal disease, you can lose a lot of albumin through the kidneys if you've got renal disease. Dietary intake, so sometimes like with old cats with renal failure, some people put them on a low protein diet and that will decrease their albumin as well. Intestinal protein absorption, so if the gastrointestinal system is not necessarily working properly, then sometimes we get changes in levels of albumin as well. Another really important thing about albumin is that it is a major binding and transport protein. Very important in what we do. For one thing, it maintains osmotic pressure of plasma. What that means essentially is that it keeps the fluid component of blood in the bloodstream, so it keeps our blood pressure up, right? Don't worry about the photometric test. So there's some diseases and conditions that are associated with alteration in serum proteins. You can have a quick look through these. One thing I wanted to mention actually before I start talking about globulins with albumin is that because it is a transport protein, and I'm not sure if I mentioned this down the line here in this PowerPoint or not, so I'll just mention it now. Because it is a transport protein for certain drugs, then if there isn't enough of it in the bloodstream, then sometimes that alters the transport distribution of drugs. It can also alter the amount of free drug that's found in the plasma or the serum, and that can really cause trouble in terms of the amount of active drug in the bloodstream. But I think I do come back to that later. Globulins. So alpha globulins are synthesized in the liver, and primarily they transport and bind proteins. There's lipoproteins, high density, very low density lipoproteins. These are alpha globulins. Beta globulins, they include complement. So C3, C4 complement is a very important part of the immune system. I know we didn't talk too much about it, but just know that these are proteins that are very important in the immune response. Transferrin and ferritin. So these are responsible for iron transport, heme binding, and fibrin formation and lysis. Gamma globulins. So I talked about these just a couple of slides ago. They're synthesized by plasma cells. They're responsible for antibody production, right? And immunoglobulins in animals. So I talked about IgG, and then there's, of course, IgD, IgE, IgA, IgM. So all of these are immunoglobulins. These are gamma globulins. So that's why when we do the electrophoresis, we can see what kind of globulins we have in our bloodstream, and this is really important. We know if we could know potentially if we have low immune function or high immune function if we're fighting something. It's very, very interesting. There's also direct chemical measurement of globulins. This is rarely done. So concentrations are estimated by the difference between total protein and albumin concentrations, and that's usually how we actually determine them. An alteration in the albumin-globulin ratio can be the first indication of a protein abnormality. So there's a range that should be in, and if you run an automated blood test, it's going to show you that range. So you can compare the ratio to what it should be. And if we find we have actually more albumin than globulin, or vice versa, that can really indicate where in the body the problem might be. We actually analyze that ratio in conjunction with the protein profile. And a lot of the pathologic conditions alter the ratio of albumin to globulin. If the concentrations are reduced in equal amounts, there'll be no alteration in the ratio. The most common cause of that would be hemorrhage, because you're losing both types of protein equally. Whereas through the kidneys, you may be losing albumin, not globulin. Basically, one is typically lost more than the other, depending on where the disease is, except, of course, in the case of hemorrhage. Obviously, this ratio is calculated by dividing the albumin concentration by the globulin concentration. So in dogs, horses, sheep, and goats, albumin is greater than globulins. This may be an important VTNE question. It sounds like the kind of stuff they'd ask you. So albumin to globulin ratio is greater than 1 in dogs, horses, sheep, and goats. In cattle, pigs, and cats, it's less than 1. So there is less albumin, the same amount or less than globulin in those animals. Fibrinogen, I've mentioned, it's synthesized by hepatocytes again, so it's a precursor to fibrin, and that's an insoluble protein that forms the matrix of the blood clots. Very important, you can't form a blood clot without it. So if you have decreased fibrinogens, you don't get clotting, or at least you don't get much clotting. Fibrinogen makes up about 3 to 6% of the total plasma protein. It's not found in serum. We've been over this. Why? Well, serum is our blood. Fibrinogen will be gone and used up. Just a note, acute inflammation or tissue damage might elevate fibrinogen levels. The values of fibrinogen are actually calculated by subtracting the total plasma protein value of a heated tube from that of an unheated tube. Don't worry about this too much. Some automated analyzers can provide fibrinogen results. Most of them don't, but we have ways of finding it if we need to. A lot of times it's sent to a reference laboratory. All right, we're moving on to liver. So hepatobiliary assays. Couple of things about the liver first. So the liver is the largest internal organ in the body. It's got a complex structure and very complex function, and interesting pathologic characteristics, actually. So the liver is complicated, basically. It's large, it's complicated. It does a lot of things, and when there's liver disease, there's all kinds of trouble. So what does the liver do? Well, it metabolizes amino acids and carbohydrates and lipids, synthesizes proteins of albumin, primarily, cholesterol, plasma proteins, and clotting factors. It digests and absorbs nutrients, it secretes bilirubin or bile, it eliminates and detoxifies toxins, and it catabolizes certain drugs, a lot of drugs actually. So very, very, very incredibly important, and again, it does a lot of stuff. So this is where things get a little hairy sometimes, but I'll try to guide you through in the simplest way I can. All of these functions are run by enzymatic reactions. And again, that goes for most of the body anyway. As part of the hepatobiliary system, we have the gallbladder. So it's closely associated with the liver. As you'll remember from anatomy, it kind of sits almost right in the middle of the liver, anatomically. And functionally, it works, of course, together with the liver. Its primary function is storing the bile that's produced by the liver. If we have malfunctions in the liver or gallbladder, so in the biliary tree, we get jaundice, low albumin, we can get problems with hemostasis. And again, if you think about that, clotting factors and proteins and that sort of stuff come from the liver. Hypoglycemia, again, liver is very much involved in controlling blood sugar levels. Hyperlipoproteinemia, hepatoencephalopathy, very, very big deal if there's something going on in your liver or gallbladder. So you may or may not remember that the liver is divided up into zones, basically, and the liver cells are able to compartmentalize damage so that if one zone is damaged, it won't affect all liver functions. So that's why sometimes we'll see one component of the liver that's not working, or one function of the liver that's just not working properly, whereas the rest of it can look fine. And that can even happen with significant liver disease. There are over 100 tests available to detect problems with the liver. And again, that's because it is so complex and there's so much that it does. And no single test is superior to any other. It's just that some of them are more appropriate to certain conditions than others. And there's always tests that are being developed to try to detect problems with the liver sooner. Here are some of the major hepatobiliary assays that we use kind of every day. So if we're looking for enzymes that are being released from directly damaged liver cells, that would be ALT, probably our most common one that we look for, Alanine Transaminase, and then we have Aspartate Transaminase as well, and that's AST. Those would be the two that we're going to look at most commonly in practice. In terms of problems with cholestasis, so that means basically bile flow through the biliary tree. So if we're looking for enzymes associated with that, ALK-Phos, so alkaline phosphatase, very much the go-to one for most clinics. The other one that we'll see a lot is GGT, and that's gamma-glutamyltransferase. So those two, GGT, ALK-Phos, very commonly looked at for cholestasis, and along with that goes bilirubin and bile acids. So I just mentioned this on the last slide. Bilirubin and bile acids are commonly run in veterinary settings. Other liver function tests are less sensitive, and unfortunately these tests often don't detect damage until 2/3 to 3/4 of the liver tissue is already damaged. We can look at albumin and cholesterol as well in terms of production in the liver, just to get an idea of how well the liver is. So a few notes on bilirubin. Bilirubin is an insoluble molecule. It's derived from the breakdown of hemoglobin by macrophages in the spleen. It binds to albumin for transport to the liver, just like a lot of things do. The liver cells actually metabolize that bilirubin, conjugate it, basically that makes it able to be secreted in the bile. And then bacteria in the gastrointestinal tract act on that bilirubin glucuronide, and they produce things called urobilinogens. And if you'll remember, that's one of those tests on your analysis that you do. Urobilinogens are then broken down and excreted in the feces, but they can also be absorbed in the blood and excreted through the kidney, and that's why we're looking at that value in urinalysis as well. This is a nice complicated slide. It's actually extremely simplified, but I won't make you remember it or anything. If you want to, you can pause the video, have a look at this. It's just, it gives you an idea of how bilirubin is metabolized within the body. Measuring bilirubin can actually help us pinpoint the cause of jaundice. We can determine the relative solubility of bilirubin molecules, and that can help us to identify them where they came from. So it's prehepatic bilirubin, so it hasn't been conjugated by the liver yet, and it's bound to albumin, so that comprises approximately 2/3 of the total bilirubin in the serum. If there are increases in that unconjugated prehepatic bilirubin, then that's usually indicating a problem with uptake in the liver. Conjugated bilirubin is measured directly, and it indicates, if it's high, it indicates bile duct obstruction. So the bilirubin's making it into the liver, it's getting conjugated, ready to be secreted or eliminated from the body, but for some reason it's not making it through that biliary tree. So if we have increased blood conjugated bilirubin, well, there's a problem getting the bile out of the liver. Bile acids are a really great way to look at liver function. So this is not something that we're going to do in every animal, but certainly if we have an animal where we suspect liver disease, this is a really good test to run. Bile acids serve many functions. Among them, they help with fat absorption and they modulate cholesterol levels. They are synthesized in liver cells from cholesterol. They get conjugated, don't worry about that. But then they're secreted through the biliary system into the duodenum, where they can have their effect. They're stored in the gallbladder until it contracts when an animal eats, except in horses. Horses are an exception to a lot of things you'll see. But usually they hang out in the gallbladder until an animal eats, then the gallbladder contracts, and then they make their way all the way into the duodenum. Once they go through the duodenum, they do their thing, they reach the ileum, then they get transported back to the portal circulation, which brings them back to the liver. 90 to 95% of bile acids are actually actively resorbed in the ileum, which is great. So we recycle them. We can use them again, right? Great. The remainder go out in the feces. So there's a little flow chart here that shows you what all happens. Basically, the bile acids go from the liver to the gallbladder, into the intestinal tract. Most of them go back to the portal circulation, end up back in the liver. Some of them end up in the systemic circulation, but most of them go back to the liver and do their thing again. Some of them go to the feces, some of them go to the systemic circulation, but this is normal. Postprandial, so after eating is what that means, serum bile acid concentrations are higher than fasting concentrations. That makes sense because they only make it into the bloodstream after the gallbladder contracts, and they help with the fat absorption, and then they go back into the circulation, or some of them do. So any process that interferes with the circulation of bile acids results in elevated bile acid numbers. Well, that makes sense. So they are also really great for evaluating the major anatomic components of the hepatobiliary system. So what that means is that we can use this test to look at anatomically and physiologically how is the liver actually working. How do we do the test? Well, we take 2 serum samples. So we fast the animal for 12 hours, and then we take a serum sample. Then we feed the animal, and then we take another serum sample 2 hours later. So we look at the difference in the bile acid concentration when the animal is fasted and after eating. Horses, we only take 1 sample. There are factors that can result in false results. Basically, inadequate fasting. We need that 12 hours in order to get a good baseline. Food aromas can actually cause some contraction of the gallbladder. Prolonged fasting or diarrhea can actually alter these results as well, so just some things to keep in mind. So say we have an animal, we do the bile acid tests, they come back elevated. So this indicates liver disease, but it doesn't tell us what liver disease. One of the most common ones that we do this for is congenital portosystemic shunts. So again, this is also sometimes called a liver shunt. Usually what it means is there's a blood vessel that's bypassing the liver. So instead of having all the systemic blood go through the liver and get filtered, some of it bypasses the liver, goes right back into circulation, and we get a toxin buildup in the bloodstream. So that's a portosystemic shunt. Congenital means the animal was born with it. There are acquired ones as well, but we're worried about the congenital at this point. Chronic hepatitis. So hepatitis, of course, being inflammation of the liver. And so, I mean, there's lots of things that could cause that, a lot of them viral, that kind of thing. So chronic hepatitis, we can have high bile acids. Cirrhosis. Cirrhosis we associate mostly with drinking, so alcohol in people. Animals, obviously, most of them don't drink, but they can get cirrhosis for other reasons. We can get elevated bile acids with cholestasis. The biliary tree isn't flowing normally for some reason, and we can definitely get these elevated. Cancer, of course. And then the other thing about bile acids, again, they're unspecific. For the type of liver problem, it's a screening test. Basically, we're asking, is the liver functioning normally? And if not, then we'll go on and try to figure out why. We already looked at this. Just in case you wanted a review, here's your beautiful flowchart. You can pause and look and enjoy. Let's talk cholesterol for a few minutes. So, it's a plasma lipoprotein that's produced primarily in the liver, but it's also ingested in food. And we know that in people, they always say, oh, don't eat too many eggs because you'll get high cholesterol. Well, actually, that's not true, but cholesterol is something that we worry about a lot in people. We don't worry about it so much in animals, except in a very select few disease processes. Cholestasis causes increased cholesterol in some species. Again, cholestasis, the bile is not flowing properly through the biliary tree, so that can increase the cholesterol for some species. It's not actually very well characterized in veterinary species. But here's the thing, we sometimes use it to screen for hypothyroidism. Hypothyroid dogs will almost always have elevated cholesterol. So if we have a dog that looks like it could be hypothyroid, it's kind of overweight, it's kind of lethargic, it's got bad skin, whatever, and it has high cholesterol, maybe we should run a T4 TSH on that dog just to see, do we actually have potentially hypothyroidism? So that's one of the most common uses for cholesterol testing in vet medicine. Cholesterol also does not cause grossly lipemic plasma after eating. So if you're spitting down a sample in an animal who's eaten in the last, hour or two, and you notice that it's lipemic, it's not cholesterol. Let's quickly talk about enzymes that are released from damaged hepatocytes. I mentioned these before, but again, as liver cells are damaged, certain enzymes do leak into the blood, and we can measure these when they start to leak into the blood, right? So we get our ALT, Alanine Transaminase, our AST, Aspartate Transaminase, and dehydrogenase enzymes. ID and GLDH, again, these are probably not ones that you're going to see commonly used in practice. These are reference laboratory tests that can be sent away for in certain situations, and your vet will decide that. Again, the only readily available tests are ALT and AST. I would say ALT is probably our most commonly looked at one. The major source of ALT is the hepatocyte. Makes sense. It's found free within the cytoplasm of hepatocytes, so that when there's liver damage, within 12 hours you can see it leaking into the bloodstream. So we'll see elevated serum or plasma levels within 12 hours. ALT is considered a liver-specific test in dogs and cats and primates, but horses, ruminants, pigs, and birds don't have enough ALT to be considered a liver-specific test. So if you're dealing with those species, not as useful to you. But again, for dogs and cats, which most of you will deal with, ALT is a really great go-to test for liver. It can be elevated by damage to renal cells as well, cardiac muscle, skeletal muscle, and the pancreas. So bear that in mind. So the results just need to be taken with a bit of a grain of salt if there's known problems in those areas. Again, the major source is the liver, and this is considered a liver-specific test in dogs and cats, and non-human primates if you happen to be working with those. It's a screening test, so it's not specific enough to identify the liver disease. Sounds familiar, right? It's like every liver test. But ALT, very commonly used as a screening test for liver. AST, also present in hepatocytes, it's in the cytoplasm, and it can be found bound to the mitochondrial membrane. It takes more severe liver damage to release AST, the membrane-bound stuff, at least. So levels will rise slower than ALT, but they return to normal faster. Interesting. AST is unfortunately also found in other tissues, red blood cells, cardiac muscle, skeletal muscles, kidney, and pancreas. So common causes for elevation could be not just in the liver, it could be elsewhere. But liver disease is probably the most common one. But muscle inflammation or necrosis could be a big one, and hemolysis. So, keeping that in mind, aspartate transaminase (AST) just has to be considered in conjunction with the clinical picture, which is of course true of all these tests. Cholestasis. So I've mentioned this several times, but here we go again. Bile duct obstruction. That's ultimately what it comes down to, right? The bile can't make it through the biliary tree. The big one that we look at in vet medicine is alkaline phosphatase, AP or ALK-Phos. This is present in osteoblasts as well. So osteoblasts, you'll remember, are cells that produce bone. Chondroblasts, cells that produce cartilage. Intestines and placenta, and liver cells. So several places this can come from. This is not a great specific test, but in conjunction with other tests, it can point towards cholestasis. GGT is found in many different tissues and comes primarily from the liver as well. Cattle, horses, sheep, goats, birds, they have higher GGT normally than dogs and cats. So again, that needs to be borne in mind working with those species. And elevated liver levels of GGT do happen with liver disease, especially if it's an obstructive liver disease. Again, obstructive liver disease, we're talking about cholestasis. So just a summary of what we've gone through so far. Total plasma proteins include fibrinogen, total serum proteins do not. Albumin makes up 35 to 40% of total protein. Liver function tests measure substances produced by the liver. Unconjugated bilirubin comprises approximately 2/3 of the total bilirubin in most species. Bile acids aid in fat absorption and modulate cholesterol levels. Elevated serum bile acids do indicate liver diseases, not specifically though. And if we're looking for leakage enzymes, ALT and AST are the ones we'll evaluate first. ALT and AST are the most common performed liver tests.